Thank you very much. It's a great pleasure to be here. I would say an honor, because I think this fantastic, this series of lectures is absolutely outstanding. It's really a pleasure to be involved in this, and thank you very much for inviting me. So this is my title. I'm going to talk about primary progressive aphasia, which I consider as an interesting and different window into brain and language. These are my disclosures. I will start with this consideration. A lot of people are interested in primary progressive aphasia, PPA. If you look at the number of papers which are published, you have the impression that it's the leading cause of aphasia. I made this very simple check, very rough, without doing sophisticated search. Number of papers in PubMed this year about PPA and post-stroke aphasia, and I got this result. More papers about PPA, and this corresponds to the impression I have. This stands, I would say, in stark contrast with the epidemiological data. It's remarkable in a negative sense that we don't have really any good epidemiological data about the primary progressive aphasia. This is one of the most of the data are based on inferences, such as this result we got from an epidemiological study I was involved with in two areas of Italy, North and Deep South. The study was not about PPA, but it was about frontotemporal dementia, and as you know, most of the cases of PPA are due to belong to the spectrum of frontotemporal dementia, and the spectrum of FTD, of frontotemporal dementia, is remarkably rare. 3 cases for 100,000 persons a year, and of these you can estimate based on the prevalence of the different form of FTD that about 40 to 60% are PPA cases. So not a very frequent condition, but maybe the interest is mainly due to the fact that it provides a really interesting data about language function, language neurobiology. So I think this is the reason why many researchers, as myself, who have been working a lot on post-stroke aphasia in the past, started to get very much involved in this. So why different? Well, I will try to focus just on one point, which is because the syndromes are different from I believe, from the syndromes of post-stroke aphasia, and I will try to convince you about that through different kind of evidence. Of course, they are different from the point of view of pathology, by definition. They are different for the clinical course. I mean, you have here a declining clinical course. People get worse, which of course is not good. It's a model which is largely different from aphasia from the point of view of the time course. And the final point, which is also of great interest, the management needs to be different, and there should be a management, I would underline. So I can't talk about all these different aspects. So I'm going just to focus on 3 points, which are the history, how this concept of primary progressive aphasia entered the field, which is an interesting story in itself. I will focus a bit on assessment, because this is an important topic from the practical standpoint of making a diagnosis, which is a necessary step in order to do research in this area. And then I will elaborate a bit on the clinical syndrome, on these clinical syndromes, their contribution to what I think is their contribution to language neurobiology. And I will leave out a lot of interesting stuff, such as the pathology and the management. So let me start from history. what is remarkable is that, as in the case of stroke aphasia, the first clinical description is of a very atypical case. Tantan was a very atypical aphasia case. Recurring utterances are not so common in aphasia. The patient described by Pick in 1892, very nicely described with a very careful, what you would call a very careful neurolinguistic description, was quite unusual from the point of view of the phenotypes of PPA we see nowadays. He was fluent, very much so, over-talkative, but he was producing what looks like a mixed jargon with a lot of neologism and phonological paraphasias. In spontaneous speech, reading aloud, etc. If you read the report, it's quite remarkable in this sense, with a very precise description of the error type. Pick was an excellent clinician, and as you know, he had a special interest in aphasia. Again, as it often is the case, this led to the definition of a disease defined according to the guy who had described it, Pick's disease. It became associated with a specific neuropathology. This is not the brain of Pick's patient. He didn't preserve it as Tantan patient, a Tantan case. Here you see the typical macroscopic anatomical appearance of a patient with primary progressive aphasia, in particular with the form associated with the Pick pathology. That is a focal atrophy, which is much more severe at the level of the frontal lobes and of the anterior part of the temporal lobes. This is the typical macro appearance. At the micro level, of course, we have the famous Pick body, which are actually described by Alzheimer's. This is another interesting story in itself. However, we know now a lot about this Pick body. You know that they are aggregation of misfolded protein, in this case, phosphorylated tau, in one specific form, which is the tau3 repeat pathology. So we had this description of what was considered a very unusual form of dementia associated with a relatively specific pathology, and then everybody forgot about it. In the sense that, I mean, when I was studying neurology, Alice, a long time ago, in my textbook, there was probably a couple of pages about Alzheimer's disease and half page about Pick's disease. Of course, cases that were described, there is a very nice clinical pathological series collected by Tissot in Geneva, etc. But it was considered a very unusual neurodegenerative disorder, and not necessarily associated with language disorder, but more with behavioral disturbances. The story restarts in the 80s. It restarts in the 80s in two different places in Northern Europe, Manchester and Lund. In Manchester, what happened was that David Neary, whose name is associated to many important landmarks in the history of frontotemporal dementia, was following a group of patients with dementia starting a bit earlier in comparison to the standard senile dementia, pre-senile dementia, it used to be called, due to cerebral atrophy, and found out that some of these people did not have the classical amnesic presentation of Alzheimer's disease, but actually had social change and conduct disorder, behavioral impairment, as well as possibly aphasia. And the other side of the coin is that he found that these people, he found it in a way which now would be very unusual, that is through cerebral biopsy, that these people did not have an Alzheimer's pathology, but they also didn't have speaks pathology. They have what he called the non-specific changes. More or less at the same time in Lund in Sweden, a group of geriatricians, actually, Gustafsson was one of them, described these several cases with a similar condition in which there was focal atrophy in the frontal and temporal lobe. They also emphasized the behavioral disorder, and they found that they were associated with in a specific change, so specific that it was called an ubiquitinopathy. Ubiquitin is a small protein which tends to link to other proteins. So there was a coloring for that. So they called these bodies ubiquitin bodies. Actually, they are made of ubiquitin linked to another protein, of which we know a lot nowadays, except how to prevent it, its misfolding. That is TDP43. At the same time, Marcel Mesulam in Chicago was describing the first for the first time in the 20th century, the syndrome of slowly progressive aphasia. And probably you all know about this famous series of patients which he described. He's here showing a brain to Sandra Weintraub and other people. This led to a rethinking of this spectrum of conditions. First by the Lund and Manchester group, they joined forces with their US mates, such as Jeff Cummings, Frank Benson, and a guy who you might also know, Bruce Miller, who has been devoting most of his work to this condition. And they put together this different condition associated with prominent frontotemporal involvement as three prototypic syndrome. Two of them were associated with aphasia. The confusion was great in the 90s with all these concepts. I would say that a landmark was the work of Marilu Gorno-Tempini, in which she carefully did something which, as people interested in aphasia, we would consider fundamental, and this is what Pix did. That is concentrated on the clinical phenotype, language phenotype, and on the corresponding pattern of brain atrophy, using the techniques which were becoming available at the time in order to analyze quantitatively magnetic resonance data. From this, the standard classification came out of three clinical syndromes, non-fluent varieties, semantic dementia, and logopinic primary progressive aphasia, which were associated to three different patterns of anatomical involvement. We'll get back to this soon. I just wanted to stress that subsequent step, quite important, was to put together an international consensus conference in order to define the clinical feature and the diagnostic criteria. This was a nice group of people who met. It was really fun because we were watching the videos of patients and then trying to reach a consensus. I would say it was international from some points of view, but most of the people were from the US. So all the linguistic features which were described were very much linked to American English, which is a point in which I'm particularly interested, that is the variation associated to cross-linguistic differences. They were not considered at the time. So one of the consequences of this consensus conference was to define the assessment procedure. And this led to the first step, the definition of first step, which is something I still like to to underline when I talk about primary progressive aphasia. In order to decide that someone has got primary progressive aphasia, you must be confident that he has aphasia as the main clinical feature. Because as you know, language impairment, in particular lexical semantic impairment, is sort of ubiquitous in all neurodegenerative, I would say in most, if not all, neurodegenerative disorder at some stage of their development. So it's really crucial that this, the language disorder is the main feature and the only determinant of difficulties in daily living. Because otherwise you are going to find a very large number of patients you could define as primary progressive aphasia, but actually they have people whose disease at some point of its unfortunate progress has involved the language area. So this is the first important point, but even more importantly, from the point of view of language research, you need to define which aspects of language you should focus on. And in this table, there is a summary of the aspects which are crucial for the diagnosis of primary progressive aphasia. And as you can see, one crucial feature which is missing in comparison to the standard assessment of post-stroke aphasia is the assessment, the concept of fluency, because we found that fluency was not very useful for classification. It was much better to define the pattern of impairment and preservation, typically in connected speech. This is the most useful task for a diagnosis of primary progressive aphasia, along a few linguistic dimensions, that is motor speech, grammar, word finding, word comprehension, sentence repetition, and sentence comprehension. And if you use this, if you have an examination procedure which includes a careful consideration of this aspect, it's relatively easy to arrive at a diagnosis according to the three main clinical categories. Of course, there are several patients who do not fit in the classification, as in all cases. I'll get back to this in a minute. I just wanted to stress that in order to allow people to make the diagnosis, we have been working a lot with a group of people. And Peter Garrett has been the person who has been coordinating this effort to develop a short screening test for classifying and monitoring primary progressive aphasia. This was done with the idea of taking into account the point I mentioned before. That is, not everybody speaks English. You might have noticed it. So it would be nice to have a test which works for people speaking different languages. So the idea is to develop a short multi-language task. We are at a good point of this in this endeavor. What is sort of strange is that the English version is the one which has not been published yet, but it's coming out. It's a very simple assessment, which, however, is based on the consensus criteria and basically includes several tasks with a small number of items in order to be usable for clinical practice, even by people who are not language specialists. In Italy, for various reasons, we were sort of faster, so we came out with the Italian version of the test, which is which can be considered as sort of a Italian version of the screening test. There are small differences because this was done earlier than the final version. However, the point is that most of the studies we've been doing in this area, leaving aside the experimental part, are based on this test, which is quite good because well, this is not unusual for language tests, but you get a fantastically high specificity and sensitivity in comparison in the distinction with normal controls and even with patients with other neurodegenerative disorders. Of course, we also developed other tests for more in-depth assessment of other aspects, such as semantics, for lexical semantics, which of course is a crucial component to be assessed, not only in the case of the semantic variant. Okay, now I move to the main part of the talk. That is, okay, you have this consensus examination. You reach a diagnosis. In our experience, in about 70 to 80% of cases, you can apply a reasonable, with reasonable confidence, the label of the syndromic label. There are other cases which are mixed, that is, they show features going across the boundaries of the categorical classification. This is another point I will talk about later. And a few patients who simply do not fit. Anyway, I think that the issue of classification in primary progressive aphasia has a special interest. The topic of classification is sort of less fashionable than it was at the time of cognitive neuropsychology. This is my favorite classification, by the way. It's by Borges, classification of living things. I really like it. Those of you who are remember the golden age of cognitive neuropsychology might remember the discussion about classification. This is taken from a paper by Alfonso Caramazza, in which, as you can say, he claims that classification of patients into categories is not only useless, but positively harmful for research into the nature of cognitive disturbances and the structure of normal cognitive processing. He might have been right, for a specific reason. That is, what is a syndrome? A syndrome, empirically, is just a group of signs and symptoms that occur together, and they characterize a particular abnormality or condition. This is the medical, practical definition. There is, however, also another level in which, at which a syndrome may fit, not always fit. That the set of concurrent phenomena form an identifiable patterns which indicates some common shared mechanism. My friend and colleague of many years, Giuseppe Vallar, wrote a nice chapter in which he introduced this distinction between the anatomical syndrome and the functional syndrome. The mixed syndrome has features of both aspects. In the case, and one point I would like to discuss with you maybe is that the stroke aphasia syndromes, which are defined on the basis of the classical taxonomy, that is rating of spontaneous speech and scores on test of language performers, are anatomical syndromes, reflecting the involvement of large-scale network components at the chronic stage. And in this case, what you are sampling is not the whole brain, but is constrained by the vascular territories of the predilection sites. I shouldn't say this being virtually in South Carolina, because the people in the aphasia department, they have done fantastic work on this in order to mitigate this issue. The primary progressive aphasia syndromes are in some way different. That is, they are generally more coherent than stroke aphasia syndromes. This is striking in the case of the semantic variant. What I say to the students is, once you see a patient with semantic variant, you are going to recognize the syndrome without any major difficulty. And in this case, the anatomical sampling is clearly different because it has a different constraint, which is not the random distribution of strokes within vascular territories, but the predilection of each pathology, which is responsible for the clinical picture, for specific sites. And the hypothesis I like is that for reason we don't understand, and this is not just the case of language syndromes, this applies also to motor disorders. The neurodegeneration pattern reflects the selective involvement of functional system, which in this case may be functional language networks. This is a very nice paper, again, from Marie-Lou. Battistel is the first author, in which they did this very nice analysis. They had the resting state network putting the seed in different areas, a meta-analysis of language activation studies, and they defined systems related to different aspects of language, broadly defined: speech production, speech perception, semantic memory, and orthography. And then they tried to characterize the PPA variants according to comparing the pattern of atrophy in each syndrome to the 4 patterns. And here you can see the results. For non-fluent variety, you have a very good match with the speech production network. For semantic variant, you have a very good match with the semantic memory network. In the case of the logopinic variant, you have a sort of mixed picture. It doesn't really fit in any of these systems. And this is a specific feature that, again, I believe it's related to the underlying pathology, which, by the way, is not frontotemporal pathology, but it's Alzheimer's disease pathology. So let me show you some, okay, I will just show you some examples of the kind of information you can get, but by studying the different syndromes. Let's start with the semantic variant, which is probably the best example of in which way primary progressive aphasia is different from stroke aphasia, because there is nothing like a semantic variant in post-stroke aphasia. No patients which really looks like the semantic variant at the stroke. My friend Lambert-Ralph talks about semantic aphasia after stroke, but it's something, and he completely agrees with this, it's a condition which is completely different, or very largely different from the semantic variant in primary progressive aphasia. It's a very interesting issue. You should, if you are interested, you should read the papers, the papers by Matt Lambert-Ralph's group on this concept. Okay, semantic variant, I will spend just a very short time on it because probably it's the most widely investigated variant. As you know, it's characterized by naming a single word comprehension impairment and an impairment which involves nonverbal semantics. What is quite striking from the neurological standpoint is that the pattern of brain involvement, the pattern of brain atrophy is quite easy to detect at the single subject level. Well, this is, I'm going to use mostly FDG positron emission tomography images because they are really good to show the pattern of hypometabolism at the single subject level, which of course is something which gives you additional information in comparison to the group studies. You see this very precise hypometabolic lesion in the left temporal lobe. What is the main source of variability is the extent of contralateral involvement and the size of the asymmetry, which in some cases can go to this difference can go towards a reversal of the asymmetry, a right side, the so-called right side variant. However, it's striking how focused the atrophy is. You might remember the first patient described by Pick and the image I show you of the focal atrophy of the temporal lobe. But again, another interesting feature. This is a study we did a few years ago. Taking advantage of the value of hypometabolism to show specific patterns at the single subject level. It's quite stable across cases. Again, there is some amount of variation, especially in the involvement of the contralateral side. But if you look at the commonalities, they are quite striking. And if you compare the commonalities to the single cases, it's quite a stereotype pattern of involvement of a set of areas with a focus on the anterior temporal lobe, but an extension to the posterior inferior part, and additional involvement of other temporal areas. By the way, if you do a meta-analysis of the semantic areas, there are several meta-analyses. This is a new one done by one of my colleagues who took into account the enormous amount of the imaging literature and this distinction among representation and control areas. You see a quite impressive match of the areas commonly activated during semantic task and the areas which are involved by semantic image, the semantic variant. I think I skip some of the slide because I'm going too long. It's a very good model to study progressive semantic deterioration, and we've done several works on it. I just can spend a few minutes about this very controversial issue of there's a whole literature on category specificity within semantic dysfunction. One of the big topics of discussion is whether abstract knowledge is relatively preserved. And you find very nice single case studies showing preservation, and other studies, especially group study, which do not find any preservation of abstract knowledge. I had this patient which was quite extreme. 36-year-old, this can be a very early neurodegenerative disorder. He couldn't name a kangaroo. It's my favorite one item test. Yes, we can find one of these in Milan. It's domestic. We don't have kangaroos here. We raise kangaroo here. It's good business, very useful creatures. And this is his definition of justice. Justice, theoretically, is the normative principle. The principle should inform our behavior and our choices. It's one of the basic tenets of society, the distinction between good and evil. Kangaroo. Actually, we found that a few patients like that. This is a group studies, and you can appreciate a point which probably explain a lot of the differences in the literature. There is a huge dispersion of the performance of patient with semantic variant on abstract concept task. And this probably quite likely reflects the extent of variation, which is all within the temporal lobe. And within the temporal lobe, it's quite likely, this is a topic very much interested in the last few years, that the regions which are involved by the process of abstract knowledge are different from those which are involved in the cases of concrete knowledge, a distinction which seems to be between the lower part of the temporal lobe and the superior, middle superior part of the temporal lobe. This is an imaging study. Just a few words about the non-fluent agrammatic variant. Here, the focus is not on lexical semantic, but is on two features: the motor speech disorder and the agrammatism. Also, in this case, you find a relatively consistent pattern, which you can see in this single case. It's basically a frontal, left frontal involvement with the focus on the insular and on the inferior frontal cortex, but it also has this sort of marker, which is the involvement of the medial frontal areas. At the neuropsychological level, again, from the point of view of the things you can, of the aspects you can investigate in this patient, the point on which we have done a lot of work is on another categorical distinction, that is action naming. And actually, we found that this is the variant of primary progressive aphasia in which there is the clearest dissociation between nouns and verbs, with an inferior performance on verbs. Another condition in which you find this dissociation, this verb processing, action names, verb processing impairment, in much more severe than the process of object names, is corticobasal degeneration. This is not surprising because many patients with primary non-fluent progressive aphasia actually are affected by the syndrome of corticobasal degeneration. This is a phenotypic diagnosis based on the pattern of clinical findings. But if you look at their PET scan, again, FDG imaging, you find that the patient who have language disorder have a pattern of brain involvement, which is very similar to the cases which have a language presentation, while the cases which don't have the language presentation are actually show very different pattern. For example, involve a pattern which is typical of Alzheimer's disease. So this is a general concept. That is, the clinical diagnosis does not reflect the pathological diagnosis, except with some probabilistic relationship. Modes, that is action, naming, that is verbs, and grammar. This is a task we've been using a lot. It's an Italian version of the Northwestern Aphasia test, in which basically you have to reorganize words, noun phrases, and verb phrases to construct sentences corresponding to a picture. And you can play around with different structures. An important contrast is the canonical structures, such as active forms or passive or object extracted question. These are the type of sentences in which patients with the non-fluent variety are very much impaired. And this is sort of nice finding we had. If you correlate this with the degree of brain atrophy, you find this bilateral relationship with the insular inferior frontal region, which is bilateral in the case of canonical, but it becomes unilateral left-sided in the case of non-canonical structures. The logopinic variety is characterized, as I said, by a huge variation. But this is because it's usually due to Alzheimer's disease. And in Alzheimer's disease, you expect to find large difference in the pattern of hypometabolism, in addition or surrounding the typical areas of involvement, which is the temporoparietal cortex. So this is what you see in the case of the logopinic variant, temporoparietal involvement, with, however, a lot of difference in the extension in the temporoparietal areas. By the way, a few years ago, we happened to see a case who was similar to Pick's case. That is, he was producing phonological jargon. And in this case, as you see, the involvement of the temporoparietal areas is extensive and much more posterior. So probably Pick's case had this variety. What we found with Marilu Gordon-Tempini when we studied a series of cases, that these patients are characterized by a severe disorder of short-term memory, which seems to be one of the hallmarks of the syndrome responsible for the disorder in repetition. So remember this, because I will finish with just a mention of this, the idea that of the information we can get from a transdiagnostic approach. Some aspects really cut across the categorical distinction, however, in a way which is not random. This is a paper we recently published in which we were looking at the type of errors. You can analyze the results on the test I described to you, rather than in terms of scores, in terms of the number of errors for each dimension, which we can define a priori. In this case, we are comparing the correlates of visual errors, of semantic errors, and of phonological errors across the spectrum of neurodegenerative diseases. And if you look at the correlates of the different type of errors, this is what you see. The study was based on the pattern of hypometabolism with FDG. These are the correlates with visual errors. This is the correlate of semantic errors, and this is the correlate. These are the correlates of phonological error across the whole spectrum of neurodegeneration. So if you look at some transdiagnostic feature, not surprising, what you find are correlation with specific systems which are independent from the pathology and from the overall clinical phenotype, but they reflect the involvement of the language system, which is dysfunctional and is responsible for producing the errors. This leads me to the final point. So we have been using a lot this categorical distinction, but it's also interesting to see how whether this can transfer to some data-driven approach. This is a very good example of this approach from Lambo Ralph group, in which he was analyzing the performance on a huge battery of non-language task of a large sample of patients with primary progressive aphasia and post-stroke aphasia. What he found were basically four, with the principal component analysis, were four factors on which several tasks loaded. That is a phonology factor, a semantics factor, a visual executive factor, and a factor of motor speech production. And the main result is that the classification was totally independent of the etiology, with the one exception, that is the semantic variant, which tended to present, again, as a sort of different disease. The semantic variant here, you see that all the cases cluster together. These are the two by two analysis according to the four principal component analysis results. So we are trying recently to do the same thing, using error types rather than the scores on the different tests. This is a work of Eleonora Caticala and her co-workers, in which we try to consider these aspects together with the imaging aspects by means of a canonical correlation analysis. And the canonical correlation analysis produced basically 3 roots, which include the imaging component and the behavioral components and their relationship. And what you can find is, again, that the semantic cluster is highly correlated with a specific brain substrate, hypometabolic substrate in the temporal lobe, and a specific pattern of errors, which is high in semantic errors and low in phonological errors. In the case of the second root, you find a relationship with syntactic errors and one of the imaging factor, which involves multiple frontal hubs. In the case of working memories, the relationship is between working memory errors and the parietal component. So this is my conclusion. I think that overall the findings indicate that the syndromes of PPA may be functional rather than anatomical, representing the phenotypic consequences of the progressive neurodegenerative mechanism, which are due to the spreading of the pathology within putative cognitive language system, and a sort of gross distinction seems to be between a semantic system, a system which is related to motor control and grammar, and the phonology working memory system. Of course, the evidence is much more consistent for the 2 variants which are not due to AD, that is the semantic variant and the non-fluent agrammatic variant. The heterogeneity is larger in the case of the logopenic phonological variant, in which there is a core syndrome, but this is associated with a high variability. And finally, I would like to stress that positive emission tomography is again playing a central role, because with positive emission tomography, you can investigate, you can get now both good topographical information at the single subject level and with the molecular traces, pathological information about the underlying pathology. And as I try to argue, actually in this field, probably the relationship is not without impact for language neurobiology. And I think I'll stop here.
Thank you so much, Stefano. That was great. A wonderful overview of a lot of work in this area. Thanks for giving your talk. We have questions in the chat box. We have a question from Jo Chevalvai. What would be a sensitive task for detection of mild agrammatism for patients speaking a morphologically rich language?
Great question. We have been, by we, I forgot the last slide. Can I have the last?
Sure. Yeah, you can show. Yeah.
Okay. I need to acknowledge all the people who have been involved in many of the studies that I just went through very fast. Okay, so this is work we have been doing. I've been doing with Marilu Gonotempini a lot. The best task at this moment, I would say, remains a careful analysis of connected speech. Of course, the idea of the Northwestern task is the possibility to investigate grammar in people who are not, who have a severe motor impairment, but it doesn't. You can play with the language-specific morphology with that task. This is actually what we did in the contrast between Italian and English with Marilu, with a lot of help from our linguist friend, Andrea Moro, for example. So I would say that it's really great. It's really extremely important to perform a careful analysis of connected speech. Then it's interesting to develop a task which would allow to do this also in patients who are not able to produce sufficiently large samples.
Yeah. We have a question from, well, we have a comment from RG Hillis that you may want to address.
Hi, RG.
Great talk and great to see you, Stefano. I agree that patients who have selective deficits in naming verbs nearly always have the non-fluent variant of PPA, but many people with the non-fluent variant show no noun-verb difference. That shows the importance of single case as well as group studies.
Absolutely. That's the same issue I was mentioning about abstract concepts. As you know, there are very careful single case studies showing selective disorders and many studies which do not show the disorder. I think it's I think that this is not surprisingly due to the difference of extent of the involvement in the temporal. I mean, the temporal lobe is a lot of stuff. So, and it's packed in a small place. So it's not surprising that you find a lot of variability. However, I fully agree with you. This clearly indicates that single case study remain very important.
Thank you. I am going to slip in a question of my own. I think the way you talked about the different etiologies as either functional or anatomical is very interesting. And it seems to me there's clearly a relation between them, which has to do with the connectivity in the brain within functional regions. So if it is the case that PPA etiologies are determined to a large extent by the connectivity between cells and regions, whereas in stroke, non-hemorrhagic lesions are typically constrained by vasculature. If that's the case, then rehabilitation in stroke aphasia might be aided by focusing on functions that can be supported by intact parts of the remaining language network. But that might be challenging in PPA because the disease spreads exactly through these well-connected regions. So if that is the case, does it make sense to focus more on alternative functions for PPA interventions? So functions whose neural substrates do not or are not strongly connected to the impaired language nodes?
Makes perfect sense. As you might know, there is now a lot of interest in rehabilitation of PPA, which is linked to a lot of interest in PPA. I think this is absolutely crucial because you know what I always underline. I've seen a lot of patients who just come back every 6 months and say, okay, there is any news about the treatment for tauopathy or TDP-43? And I say no, and then they don't come back. I mean, after a while they say, what's it? So we really need to have management for these people. And it's, I think I like very much your idea. Actually, I think this is something which should develop much further. What in our brief experience, and Marilu and Maya Henry in Texas are collecting a lot of data about this. It's quite clear that the traditional speech therapy or many of the traditional speech therapy approaches you use in stroke do not work because in primary progressive aphasia, you are not trained. I mean, you have one positive side that sometimes the patient are young and have some preserved learning ability. But on the other hand, you are not aiming at an improvement. You are aiming at communication and the preservation of communication. So there is clearly a need of many more people in speech therapy with expertise in speech therapy getting involved in this, because it's a very felt need by the community of people affected by this disease, which used to be underdiagnosed. Now it's better from this point of view, but sometimes people do not appreciate how severe and terrible disease from many points of view, because you remain in a clear mind and you are told, okay, your ability to express yourself is gonna disappear. It's really crucial to find effective rehabilitation approach where effective is targeting something which is feasible.
Yeah. Thank you. A question from Kirana Tsapkini. Hi, Stefano.
Hi, Kirana.
Thank you for a wonderful and thought-provoking talk. Would you agree with some researchers' opinion that the logopenic variant of PPA does not qualify for being a syndrome? What do we do in this case? Do you think we need more syndromes within the syndrome? And if so, is this syndromal view helpful at all? And in the case of the logopenic variant, could we just characterize it as aphasic AD, keeping both the pathology and the language deficit? I will not even enter in the debate between primary progressive apraxia of speech versus non-fluent agrammatic PPA. After taking decades to remove syndromes from the study of post-stroke aphasia, are we going backwards in the case of PPA, especially when we want to learn about language in the brain rather than clinical management?
I agree on many of the things you say, Kirana. Syndromes can really be a backward move unless they have some biological significance. That was exactly my point. I mean, if it's a long story and maybe I don't have the time, but think about, for example, motor neuron disorder. Okay, it's a disorder in which the neurodegenerative process, which is, by the way, related to the spectrum, it's TDP43 basically, targets one specific system, that is the motor system. What I wonder, but this might be completely wrong, but what I wonder is, it might not be the case that the primary progressive aphasia syndromes are very different from the syndrome which were actually obscuring the differences you were thinking about, but are actually leading us to understand that there is actually a semantic system, meaning a neural system which is really dedicated to semantics. And in the case of the logopenic variety, maybe I believe that there is a syndrome, and of course the evidence is much more tenuous than in the case of the other variety. But my speculation, maybe this is a syndrome which relates phonology with working memory, as we see in, as we have elaborated in the past for cases with selective short-term memory impairment. And of course, in the case of the non-fluent agrammatic variant, are we seeing, I shouldn't say this because it's a highly controversial point, a relationship between the motor system and grammar?
That's a nice cliffhanger there. So we have a question from Brenda Rapp, which is kind of related to what we talked about earlier. With regard to the functional syndrome claim, in parentheses, is there, in quotation marks, is there clear evidence that the disease progression is constrained by the functional anatomy of a particular language subsystem, for example, semantics, syntax, etc., rather than by neuronal proximity to the locus of the disease onset?
Well, the short answer is no. Clear evidence, no clear evidence. Again, I would fully agree it's a speculation which is based from reasoning in general about a neurodegenerative disease and the idea that neurodegenerative disease have a starting point and a diffusion by protein, pathological protein spreading. You are absolutely right, Brenda, in pointing out that then you should have an idea of where the process starts. We have evidence. We have very nice idea in the case of Alzheimer's disease. We might have some idea in the case of some phenotypes of frontotemporal dementia, but of course it's much less direct. You know the story about the phonoeconomo neurons in the behavioral variant. You know what? In the case of language, we run into the usual problem. We don't have any more models. So it's really difficult to show, to have clear evidence. It's a speculation based on, I would say, that the strongest point is the lesser variability in the case of at least two of the variants. In the case of logopinic aphasia, as Kirana was pointing out, is much more, I mean, it's becomes a matter of discussion about actually the clinical features of the syndrome.
Thank you. We have a follow-up comment from RG Hillis. RG says, we find the Northwest anagram test does not distinguish between variants at all. It depends on comprehension and working memory as well.
This is interesting because we found the distinction. Maybe this could be related to the morphological difference between English and Italian. Mm-hmm. This is a very interesting point, I think, because as I was trying to explain, of course, we had to, in order to adapt the test to Italian, we had to do some quite subtle morphological modification. For example, in the use of plurals, and maybe this made the test more sensitive to the non-fluent variant. Should be tested in other morphologically rich languages. By the way, the person who made the question about test for morphology, this would be very interesting to test in Finnish, Turkish.
Yeah, we actually have a follow-up from Zsolt Szefalvai on that on the topic as well. Would you expect to see a dissociation between low motion content verbs and high motion content verbs in non-fluent variant of PPA, like we see in patients with Parkinson's disease?
You know what? I don't know if anybody has done this. This would be extremely interesting, considering that you could test this also in patients who have non-fluent aphasia and a Parkinsonian-like Parkinsonism, such as in CBD or PSP. It's a very good idea.
Thank you. And I think that's where we want to end it today. Thanks so much, Professor Cappa. Thank you, Stefano, for your talk. I think we all really enjoyed it. That's pretty clear from all the questions also. To the audience, oh, sorry, go ahead.
I would like to thank you for the question. They were great. I got some great ideas.
Beautiful. We will see you again at C-STAR on November 4th. Thanks, everyone, and have a great night or day.